The purpose of this lecture is to review quickly and a little bit superficially some important entities in dermatopathology. So that way you just get a sense of the wide range of diagnoses that you should be expected to know for your exams. And you can read further and deeper into each particular entity if it piques your curiosity or you want to know more. But when it comes time to review for boards, you really have to have more of a pattern recognition, instant diagnosis strategy. And so we're going to go through a series of still images here, and the diagnosis that was rendered will be discussed briefly, and we'll just continue to move until we cover 100, 200 entities or so. Take a look at the structure of this. What type of process do you think it is? Do you think it's an inflammatory process, neoplastic process, a cyst, or a deposit? What's your diagnosis? Trichofolliculoma. So trichofolliculomas are composed of small daughter hair follicles that lead into a central mother hair follicle and then protrude out through the follicular ostia. It's a type of adnexal tumor that recapitulates portions of the hair follicle, obviously to the outer edge. There's a lot of normal looking hair follicles, but they're just clustered together and they lead into this central large hair follicle. Trichofolliculoma. Some people may mistake this for a basal cell carcinoma. It's not a basal cell. So from this power, you can tell it's well circumscribed. It's got an edge that looks like it's peripherally palisading. From low power, what's your differential diagnosis? What if you went on high power and found abundant clear cells making up this neoplasm and an eosinophilic rim to the outer edge? Trichoadenoma recapitulates the isthmus catagen phase. It mimics the outer root sheath. So if you look at normal outer root sheaths of the hair follicle, you'll find abundant clear cells, and this tumor actually has abundant clear cells. Lighter basaloid cells, peripheral palisading with sometimes overlying verrucous appearance. So they can be misdiagnosed as warts. It can be misdiagnosed as basal cells. Immunohistochemistry wise, if you did a Barrett-4 on this, you would be able to see that pretty much the entire tumor is negative for Barrett-4. But if you did a CD34, it would actually highlight most of the clear cells. So that's a high yield immunohistochemical question for trichoanemomas. Remember, trichoanemomas are associated with Cowden's disease. Just a quick reminder that trichofolliculomas are often associated with Birt-Hogg-Dubé syndrome. What's your diagnosis? So from this power, you would probably be entertaining a squamous cell carcinoma because of the abundant glassy appearance from low power. Looks to be, it's a little unclear where the epidermis was, but perhaps you're imagining it's endophytic in some way. This is a proliferating pilar tricholemal cyst. So what you see in these are hyperplastic squamous epithelium that consists of a basaloid germinative layer, stratified squamous cells, and marked glycogenization, as well as abrupt keratinization without a granular cell layer. You can see the fibrotic stroma with dystrophic calcification. You should not see overtly atypical cells with abundant mitotic figures, but rather you can see some cytologic atypia because this is proliferating and there can be some reactive cellular atypia within the setting. Many people mention this buzzword of rolls and scrolls. So You can imagine this looks like some type of scroll rolled up. You can see some smaller little circles within a larger circle. I tend to think that if you see a really well circumscribed tumor, you see some areas of calcification, some areas of what we would call tricholemal keratinization, where you don't have a granular layer, but you do not see the shadow cells of a pilomatricoma. You can think about a proliferating pilar tricholemal cyst. What's your differential diagnosis? This is a trichoepithelioma. So if you were thinking a micronodular basal cell from this power, don't blame yourself. It's hard to tell at this power what you're looking at, but even from this power, you can see that it's a basaloid tumor without a lot of retraction around the tumor proper. So you just have these really well-formed basaloid islands. You've got some areas of potential calcification. It's pretty well organized. The cells are bland if you go on high power. So it's a well-circumscribed nodule with multiple basaloid epithelial islands. And these resemble the hair bulbs embedded in an eosinophilic stroma. Papillary mesenchymal bodies are often seen in this entity. Clefts between the stroma and the stroma are more common, as opposed to clefts between the cells and the stroma. The fibrotic stroma can make you think about a micronodular basal cell from this power. You can watch my unknowns where I cover several different adnexals, and you can look at the digital slide and compare and contrast. What's your differential diagnosis? Pilomatricoma often has rims of very deep blue basaloid cells and adjacent areas of acellular eosinophilic skeletons of previous cells. And so those are often referred to as ghost cells. And so a little Halloween theme for you. The ghost cells are pretty spooky, but when you see them, they're actually quite definitive for this diagnosis. Pilomatricoma, some people call it pilomatrixoma. I would explore, this is a low power image just to give you the architectural variation, but I would look up some images in your resources and get a good feel for ghost cells, or shadow cells as they call them. Ghost cells is another term that's used for pancreatic paniculitis, where you have these areas of saponification that take on this round architecture. However, I don't really believe that those are the same size as normal cells. They're actually quite bigger. So I'm okay personally if someone refers to these as ghost cells or shadow cells. Either way, I know what they mean. Now, these can have a high mitotic rate. It does not mean it's a pilomatrical carcinoma. We often see these in kids as a subcutaneous calcified nodule. There can be a surrounding granulomatous response as well. Review many examples of pilomatricoma because you're absolutely expected to be able to recognize that. High yield facts include increased in beta-catenin activity in pilomatricoma, and there are many different syndromes that you should be able to associate with pilomatricoma. Myotonic dystrophy, Gardner syndrome, Rubinson-Taybi, Turner syndrome. There's many different syndromes that you can associate. If you see 6 or more pilomatricomas in a patient, you should work them up for some type of syndrome. This one should be a little bit more on the easy side. You can tell it's on the scalp. There's many different sebaceous glands here. Some of them directly connect to the overlying epidermis. So Nevus sebaceous, this is an immature neoplasm at this point with irregular epidermal hyperplasia. Usually you can see vestigial hair structures with basaloid budding identified adjacent to the superficial immature sebaceous glands. You may have vertically arrayed ectopic apocrine glands, and you may have plasma cells in the stroma. Most of the examples I've seen of these, you have abundant apocrine glands to the deep aspect of the excision. You can also see several anagen hair follicles, So you can tell it's the scalp. There's an increased number of sebaceous glands attached to the epidermis. So this is definitely one you need to know. Interestingly, Nevus sebaceous can be associated with multiple adnexal neoplasms within the same specimen. Nevus sebaceous often presents as just an alopecia plaque on young kids, and sometimes it can be so thin it's difficult to tell if you're dealing with some type of aplasia cutis congenita or a developing Nevus sebaceous. However, if it's got a yellowish hue to it, you can think about a developing Nevus sebaceous. What's your diagnosis here? What cell lineage do you think that this is arising from? So this is a sebaceous adenoma. You can see that there are multiple well-differentiated sebocytes, and they take up approximately 50% of the tumor. Now, if you have more than 50%, that's definitely sebaceous adenoma. If you have less than 50% of the well-differentiated cells, then that can be considered a sebaceoma. This is a somewhat of a borderline tumor because it's getting close to being a sebaceoma, but these really well-defined lobules here would allow someone to argue that it's an adenoma. Sebaceous adenoma and sebaceoma are benign. Sebaceous carcinomas, though, need to be completely excised with negative margins. Unfortunately, sebaciomas can look exactly like sebaceous carcinomas, vice versa, depending on the sampling. So in real life, we often sign these out as atypical basaloid proliferation. Excision is required to be able to rule out a sebaceous carcinoma. Of course, you can see abundant sebaceous neoplasms in Muratori Center. The IHC that you want to make sure that you know are 4 different types of proteins that are stained for, and if you see a decrease in one of them, then you could consider that it may be consistent with Muratori. MLH1, MSH2, MSH6, and PMS2. What's your diagnosis? This is a basal cell carcinoma, but it has sebaceous differentiation. So you see this really well circumscribed basaloid proliferation with peripheral palisading, but in the middle of them, you have some areas of sebocytes. So sometimes basal cells can just spawn off sebocytes, interestingly. If you did a Barrett-4, most of this tumor would be positive, and an adipophilin or even a PRAME stain should be positive within the well-differentiated sebocytes. For those of you not familiar with PRAME, I can do another lecture where I kind of delve into the specifics of PRAME. Running along the theme of sebaceous neoplasms here. What do you think? So this is a sebaceoma. You can see that it's much more basaloid. From this power, you could not be able to tell if it's a sebaceous carcinoma or a sebaceoma. You really have to go into the center of the lesion and look around for mitotic figures, abundant cellular atypia. There appears to be necrosis in the center part. And so, being worried about a sebaceous carcinoma is completely reasonable here. In reality, the most important features of a sebaceoma versus a sebaceous carcinoma include things like invasive architecture. That argues more for a sebaceous carcinoma. Abundant cellular pleomorphism and mitotic activity. Now, you can have some mitotic activity in a sebaceoma. Abundant necrosis, clinical growth behavior. A lot of these types of parameters you would expect in any aggressive malignancy. And so, in my opinion, there's no reason to leave a sebaceoma behind. Just excise it because you don't want to undercall a sebaceous carcinoma. For the purposes of an exam, they would probably give you a lot more clear-cut example, so that way you don't have to debate sebaceoma versus sebaceous carcinoma. In fact, for your dermatology boards, you're probably just going to want to be able to recognize sebaceous adenoma versus sebaceous carcinoma. And a sebaceoma is more difficult, but you should be able to diagnose it if it's really well circumscribed and lacks significant invasive architecture, significant cellular pleomorphism, and significant necrosis. This is actually a thin basaloid tumor with some areas of vacuolization and sebaceous looking differentiation. And so this is kind of a sneaky sebaceous carcinoma. They are usually on the eyelid as irregular lobules in the dermis with connection to the overlying epidermis. This is a very thin sebaceous carcinoma, but you can have really massive ones too, depending on when it was biopsied. Note the basaloid appearance with numerous vacuolated cells and hyperchromatic nuclei, mitotic activity, which is hard to appreciate on this power. Individual cell necrosis. It looks like a squamous cell with admixed sebaceous cells. I also think they can look like basal cells. And so it can be pretty difficult sometimes to separate out a basal cell with sebaceous differentiation versus a sebaceous carcinoma. In this example, you don't see as much peripheral palisading as you'd expect to see in a basal cell carcinoma, not as much mucin, and no retraction between the tumor and the stroma. What's your diagnosis? So you could probably tell you were in acral skin with that abundant hyperorthokeratosis. You can appreciate the fibrostroma underneath it. So this is a supernumerary digit. You'll want to look for multiple nerve twigs. That helps you remember that you're dealing with a supernumerary digit as opposed to an acral fibrokeratoma, which would lack those nerve twigs. The nerve twigs resemble a traumatic neuroma. The nerve twigs are oriented longitudinally as opposed to more random orientation in a traumatic neuroma. If you can see my arrow, I'm circling a Meissner corpuscle in the papillary dermis on the right. These are the sensory organs, many organs that are responsible for light touch. What's your differential diagnosis? So we just talked about a supernumerary digit. Now we're dealing with a acral acquired digital fibrokeratoma. So this looks very similar. You've got hyperkeratosis, you've got irregular epidermal hyperplasia and papillary dermal fibrosis. The collagen bundles are oriented perpendicular to the surface, but there are no eccrine ducts, there are no nerves. This is a acquired digital fibrokeratoma. You will be expected to be able to diagnose this on a snapshot image. What's your diagnosis? This is a special stain to give you a hint. So infantile digital fibromatosis is usually at acral sites. You've got a proliferation of scar-like fibroblasts that are arrayed with red droplets. So if you go on high power and you see some areas of eosinophilic droplets, they typically will stain positive with this Mason's trichrome. You can really appreciate the red droplets here. They're thought of as perinuclear eosinophilic inclusion bodies. So the other name for this is inclusion body fibromatosis. It's thought that the inclusion bodies consist of the protein actin. They can also stain with a stain known as PTAH, infantile digital fibromatosis. A very basaloid tumor here, well circumscribed islands. You can see thick eosinophilic rims on the outer edges. This is a cylindroma. Many people say these pieces fit together like a puzzle. The key diagnostic feature is thickened hyalinized basement membrane, which is composed of type 4 collagen as well as laminin. This is composed of two cell types, a palisading basaloid cell type in the periphery with scant cytoplasm and round nuclei, and a centrally located cell type with pale cytoplasm and vesicular nuclei. The lobules may have eosinophilic droplets, and these eosinophilic hyalinized cuticles surround the islands of the cells. Now, you often in real life have cylindromas and spiradenomas in the same excision specimen, and this is because they arise from mutations in the CYLD gene. So CYLD mutation is often associated with a syndrome called Brooks-Spiegler. This is the spiradenoma. So you've got big blue balls in the dermis. They actually can, if you go on certain areas of this, you can see areas that look like a cylindroma. So they are related, but for purposes of testing, they should show you either the puzzle piece image or the big blue ball image so you can separate out between a cylindroma and a spiradenoma. You can see small ductal formations in these neoplasms. Again, these are derived from eccrine ducts. Small foci of hyalinized matrix, the ducts with 1 or 2 layers of flattened cuboidal cells. And you can see on higher power these collections of hyalinized eosinophilic stromal globules, which are essentially made of the same type 4 collagen and laminin that form the outer layer of the jigsaw puzzle pieces in a cylindroma. Monotonous cells, fibroedematous stroma, rare ducts. This is a spiradenoma. For the next section of the lecture, we will cover paniculitis.